Hi guys, I'm Selena and I did my case study on spondylolysis. So first, just for a patient history, my patient was a 14-year-old female who presented with extreme lower back pain that was resulting in numbness and tingling down her thighs and legs. The patient had difficulty standing for long periods of time due to the severity of the pathology, which we will see soon. Just for an anatomy review, we obviously have L1 through 5, and then the superior view of the vertebrae. You can see the body, the pedicle, the superior articular process and facet, and the transverse process and the spinous process. And then in the lateral view, you can see the superior and inferior articular processes, the side of the pedicle and body, and then the transverse and spinous process. So for the AP view, just some technical factors. There is a minimum SID of 40 inches. You want to use a 14 by 17 IR in portrait, and then you want to use a grid with a KVP between 75 and 90. The patient should be supine with arms at their side, and this can also be done prone. And then the knees and hips should be flexed to reduce lordotic curvature for patient comfort. And then the CR should be perpendicular to the IR. There are two different IR sizes that can be used. So with a 14 by 17, the CR should be directed to the iliac crest, and then for an 11 by 14, the CR should be to the level of L3, and both just show different amounts of anatomy, which we will look at soon. So for positioning, the first criteria is that no patient rotation is indicated by SI joints equidistant from spinous processes. I said met for this since there is no obvious rotation present. The SI joints do seem to be equidistant from the spinous processes. That being said, there is a slight tilt of the patient in this projection, but it did not cause any rotation or anything. The spinous processes in midline of vertebral column and transverse processes of equal length. I said met for this since the spinous processes and everything seem to be of equal length and in line with everything else. The next criteria is that there's open intervertebral joint spaces, and I said met for this since all the joint spaces do appear to be open. And then for collimation to area of interest, I did say not met for this just because I think the image could have been collimated side to side just a little bit more, and obviously since the patient was tilted it kind of looks off, but I do think the positioning was okay. For anatomy demonstrated, for the first criteria, it is that the lumbar vertebral bodies, the intervertebral joints, spinous and transverse processes, SI joints, and the sacrum are shown. I said met for this since all of these parts of the spine are shown in this projection. And then approximately T11 to the distal sacrum is included. I said met for this since you can slightly see T11 up here, like beginning to see it, but this also could have been not met since it's not really shown, but it is approximate, so I stuck with met for it. Again, the anatomy criteria is based off of the 14 by 17 IR since that's what I used. And then for the exposure, the first criteria is that there is clear demonstration of bony margins and trabecular markings of the lumbar vertebrae. I did say met for this since everything in the image seems to be clear. And then I said met for no motion as well because there is no motion in this image. And then for the oblique technical factors, again, an SID of 40 inches, you want to use a 10 by 12 IR size in portrait, a grid, and then again the 75 to 90 kVp range. The patient should be semi-supine with their head on the pillow, their body rotated 45 degrees with spinal column to the midline of the table. A 50-degree oblique is best for L1 and L2, and the 30-degree is best for L5 and S1. This is averaged to 45 degrees since the different amount of rotation will display different areas of the zygoepiphyseal joints a little bit better. They'll be open at different degrees better. And then your CR should be perpendicular to your IR, and your CR should be directed to L3 at the level of the lower costal margin, or 2 inches above crest, and 2 inches medial to the upside ASIS. For positioning, the first one is accurate 45-degree patient rotation as indicated by open zygohypophyseal joints in the pedicle between the midline and lateral aspect of the vertebral border. I said MET for this since you can clearly see the open zygohypophyseal joints and the pedicles all in the correct spots. You can see right here. The next criteria is that if the pedicle is demonstrated closer to the midline of the vertebral border and less of the pedicle is seen, this indicates over-rotation. I said MET for this because the pedicle does not appear to be closer to the vertebral border. I think it is relatively in the middle on almost all the vertebrae, so there's no over-rotation present. For the next one is that if the pedicle is demonstrated laterally on the vertebral border with more of the lamina demonstrated, this indicates under-rotation. I said MET for this as well since the pedicle is not demonstrated laterally in either of these images, so there is no under-rotation. And then collimation to area of interest, I said not MET just because both of these images could have been collimated a little bit more up and down, and even if side to side a little bit as well. For the anatomy demonstrated, the only criteria is visualization of zygohypophyseal joints, and I did say MET for this because you can clearly see the joints in both obliques. And then for the exposure, the first criteria is that there is clear demonstration of bony margins and trabecular markings of lumbar vertebrae, and I did say MET for this because everything does appear to be clear. And then for no motion, I said MET for that because there's no apparent motion. For the lateral technical factors, again, minimum SID of 40, 14 by 17 IR. The KVP range does jump to 80 to 90. And then for the lateral, you do want to use lead masking on the tabletop behind the patient just for scatter reasons to get a better looking image. The patient should be in a lateral recumbent position with their knees flexed and the mid-coronal plane aligned to the midline of the table. For a 14 by 17 IR, the CR should be to the iliac crest to include lumbar vertebrae, sacrum, and possibly coccyx. And then for an 11 by 14 IR, the CR should be directed to L3 at level of the lower costal margin and should include the 5 lumbar vertebrae. For the lateral positioning, the first criteria is that the spinal column is aligned parallel to the IR as indicated by open intervertebral foramina and open intervertebral joint spaces. I said MET for this because everything looks open in this image. You can see the joint spaces right here. And then for no rotation indicated by superimposed greater sciatic notches in posterior vertebral bodies. I did say MET for this for the regular lateral and the flexion lateral. I did say not MET for the extension, which is right here in the middle, and I only said this because I feel like when you're looking at the greater sciatic notches, like down here in the posterior vertebral bodies, that there's just slight under rotation. I feel like the patient could have been rotated up a little bit more. And then collimation to area of interest, I said not MET because all of these images could have been centered and collimated just a little bit better. For the anatomy demonstrated, the intervertebral foramina, L1 through L4, the vertebral bodies, intervertebral joints, spinous processes, and the L5-S1 junction. I did say MET for this since in every image all of the intervertebral foramina and spinous processes are seen. And then depending on the IR size used, the entire sacrum may be included, and I said MET for this since I did use a 14 by 17 and the sacrum was included on each image. For the exposure, there is clear demonstration of bony margins and trabecular markings of lumbar vertebrae. I said MET for this because everything does appear to be clear, and then I also said MET for no motion. For the L5-S1 spot, For this one, you want to use an 8x10 IR size, and your KVP range goes to about 85 to 95. The patient, again, should be in the same position as the lateral recumbent with knees flexed and the mid-coronal plane aligned to the midline of the table. For this one, the CR should be perpendicular to the IR if waist support is being used, and if not, then a 5 to 8 degree caudal angle should be made on the tube and should be directed about 1.5 inches inferior to the iliac crest and 2 inches posterior to ASIS. For positioning, no rotation of the patient evidenced by superimposition of greater sciatic notches and posterior borders of the vertebral bodies. I said met for this since the greater sciatic notches and posterior borders appear to be superimposed. Correct alignment of the vertebral column and CR indicated by open L5-S1 joint space. So I did say not met for this just because obviously because of the sacral displacement, you can't really tell if the joint space appears open or not. If it was more aligned with her spine, I would assume that it would be, but because of the circumstances, I did say not met. And then collimation to area of interest, I said not met as well because I think the positioning could have been brought up a little bit more and collimated on both sides. For the anatomy demonstrated, the L5 vertebral body, first and second sacral segments, and L5-S1 joint space. I did say met for this because all of that anatomy is demonstrated. For the exposure, there is clear demonstration of bony margins and trabecular markings of the L5-S1 region. I did say met for this because you can clearly see all of the markings and margins. And then I said no motion for this as well. So for the radiology report, for the findings, there's 5 non-rib bearing lumbar type vertebral bodies noted. There's mild height loss affecting the L5 vertebral body. Otherwise, vertebral body heights are maintained. And then there is a bilateral pars defect at L5 with complete anterior dislocation of the vertebral body of L5 over S1. Bilateral pars defect, again, it's just stating it again, and then the indication was spondylolysis. So for spondylolysis, the definition is that it is a defect or stress fracture in the pars interarticularis of the vertebral arch. This typically occurs in the lower lumbar region, but sometimes occurs in the cervical vertebrae. And then these are just some pictures showing this defect. So in the top image, you can see the defect right here on the lateral and then in the oblique as well. In the second image right below, it just shows different pathologies of spondylolysis and spondylolisthesis and what they would look like. Right here you can see the anterior dislocation of the L5-S1. Then there's just another image, and then in the bottom right, you can see what the vertebrae looks like coming forward. For symptoms and treatment and prognosis, so some symptoms are just lower back pain and hip pain, muscle stiffness, muscle spasms, sciatica. Treatments, pretty typical. It's usually just non-steroidal anti-inflammatory drugs, physical therapy, or a lumbar brace. Obviously, in this situation, as you guys saw by the images, it was very severe, so she did end up having surgery, and I do have post-op images to look at as well. And then for prognosis, the prognosis is generally pretty good. Most patients recover relatively pain-free and are able to return back to normal activities. So these are some CT images that were taken on the same day as those x-rays that I took. As you can see, there is extreme anterior dislocation of the L5 vertebrae, S1 segment. The pars interarticularis and spinous processes appear to be way more posterior compared to the vertebrae, and you could see this in the x-ray projections as well, obviously. And then these are just some post-op images. These are from a couple months ago, or like 1 or 2 months ago, and the prior x-rays were from about 5 months ago, I believe. There is, if you look at the lateral, there is definitely still a little bit of an anterior displacement present, but it is much better than before, and obviously these screws will help to keep the joint space closer together and keep everything in place. And that's that.